goal of the study was to basically quantify the macroeconomic societal cost of rare diseases and show what those costs are, generally speaking, on society when you have a treatment for a rare disease, when you don't have a treatment. And we decided to do this study to understand exactly and quantify what those costs were. We don't necessarily have we didn't necessarily have a good benchmark. Now we feel we have a bit of a better indication as to what is the order of magnitude of that cost. And we also wanted to understand that if in principle, we have an indication that a rare disease treatment, when a treatment is in fact approved for a specific rare disease, generate or destroy value for society. So those were the two main goals for the study. So as you know, rare diseases are a very complex problem. There are 7,000 known rare diseases and counting. They go up by the day. And the complexity of them is that everyone is different and every one of them requires a specific expertise. Also, a lot of the diseases are very poorly known or unknown. A lot of them have been described in the literature relatively recently. So there isn't a whole lot of knowledge about them. So we had to basically make a selection in terms of methodology and decide which diseases to study better than others. So what we did was we sat down and reviewed a significant number of publications, general publications in the space of rare diseases, and decided to prioritize the first, say, 380 or 400 diseases to make a round number. And we prioritize these diseases based on the relative amount of knowledge that is available out there in the public domain compared to the more scarce knowledge which is available for the other 6,600 diseases. We then went out and formed a panel of experts in rare diseases, which includes key opinion leaders in various different areas, patient advocacy groups, groups, umbrella groups such as Every Life Foundation, NORD, as well as Global Genes. We spoke to them. We also spoke to ICER. And based on this panel, we were essentially able to distill a panel of 24 different diseases, which we cluster in 5 categories, which we call archetypes. And they're essentially comparable to therapeutic areas, if you want, that we felt where they basically had 2 specific characteristics. In our opinion, there was no specific bias to them, meaning we didn't provide any privilege to a specific rare disease compared to others, in the sense that the 24 of them were, in our opinion, to the best of our understanding right now, representative of the entire 400 rare diseases, and therefore of the entire spectrum of rare diseases. Some of these are much less known than others. Others are better known. For some of these rare diseases, there are treatments. For others, there are no specific treatments. And then secondly, these 24 diseases are, in our opinion, relatively better known than others. Some of these, as I said, are less known, but generally speaking, some of these rare diseases, these 24 rare diseases, are better known than some of the other 6,600 rare diseases, some of which have been described only in the last few years. So we distilled the list down to 24 different rare diseases. And for each and every one of these 24, we actually went out and built a significant database that has allowed us to quantify specifically the cost of each rare disease. Generally speaking, what we tried to do was we tried to quantify the cost for each rare disease on a per patient per annum, per patient per year. We cluster the costs in 3 different buckets. The first one is what we call the direct costs. And the direct costs are essentially related to the direct treatment cost if there is an approved pharmacological therapy. They might also be related to non-treatment costs. So if there are any specific medical procedures that you can think of, for example, a kidney transplant or a heart transplant, any organ transplant or a splenectomy, these are also included as a cost. We also try to factor in other direct costs, such as the cost of hospitalization, the cost of visits by the physicians or nurses, I'm sorry, the cost of home healthcare and other medical costs. So that's the first bucket. The second bucket is essentially represented by what we call the indirect costs. These, for the most part, these represent foregone opportunities for patients and caregivers and their families. So you can think of these costs as productivity loss or work loss, or also costs that are related, actual out-of-pocket costs that are related to making changes to your life because you have that rare disease. For example, if a patient is wheelchair bound, then the family might incur costs related to, home modifications to accommodate the wheelchair and enable, lifting, transportation, movement, and so on. And also traveling and accommodation for patients that want to have access to a specific clinic, for example, as part of an expanded access program, a compassionate use program, and just generally speaking, travel and transportation costs, which are related to getting access to the direct treatments. The third bucket is the mortality costs. So this is a particularly interesting area where I think we've broken some new ground in our opinion, but we try to base this all on publicly available information. So the question is, if a patient dies, what is the destroyed value that society shoulders? And we've been able to show that there is destroyed value, there is unfortunately a reduction, an increase in the cost, reduction in the value, essentially because people have a value to their lives. And if you go to our main source, which is the United States Department of Transportation, you will see that that value is essentially around $10 million. To be exact, the estimate dates back to 2015, if I'm not mistaken, and the value was $10.3 million. So that's basically the value of a life to society. And if I want to be even more specific, that value is essentially the value that every individual on average is willing to pay according to an analysis done by the Department of Transportation to reduce the risk of dying. Okay, so we can have more of an analysis and a debate on that, but that's basically the value. And that's 10 million over 75 years. So it's about $130,000 a year that you're losing for every year of life that a patient loses. So if a patient loses their life very soon, obviously that amount is much more significant than a patient that is able to get into a geriatric age, say close to those 75 years, where theoretically, according to this model, it's very theoretical again, that value lost is limited. And what we did was we probability adjusted the loss of value for society based on the probability of dying of a specific patient affected by a specific disease, and therefore probability adjusted the stream of values, of annual values that is lost if a patient dies in year X. What we then did was we took a step back and said, okay, let's compare diseases. Let's compare a situation where for a specific disease, we analyze the costs with the treatment, direct, indirect, and mortality costs. And then we analyze the same costs in the presence of a treatment. So when it comes down to mortality, for example, we did a pretty significant literature search. And for each specific disease, for each specific treatment or treatments that are indicated for that disease, we understood exactly what is the expected additional number of life years that are added by that specific disease. And based on that, we've been able to estimate the number of years on a probability adjusted basis, which are added by that disease and by that treatment. And therefore, with that, we've been able to estimate the added value, i.e. the reduced mortality cost, which is driven by that specific treatment. I want to say it's probably four different results that I want to speak about. So the first one is that we've been able to show that the average cost per patient for, again, per annum on an annual basis for a rare disease treatment is significant. It's about $260,000 a patient a year, and it's 10 times larger that of a mass market disease. Okay. Again, this is an average, right? So if you take any specific disease, whether you're talking about a rare disease or its benchmark, its comparison as a mass market disease, it's going to be wrong, right? Because we're taking the average. However, the explanation for this is that a lot of the rare diseases are genetic in nature, about 75%. And because of that, they happen to be pediatric disorders that have a lifelong impact on the life of the patient. And then additionally, a lot of these genetic rare diseases are rapidly progressive, they're heavily debilitating, and they're often conducive to death, unfortunately, which is probably why the cost per patient is so much more significant than for a rare disease than for a mass market product or a mass market disease. The second result, which I think is worth noting, is that when there is a treatment that is approved for a specific condition in a rare disease, there is added value to society. When the treatment is approved, the annual average cost, according to our analysis, goes from $240,000 to $250,000 to about $200,000. Okay, so there is that reduction of about 20%, of about $40,000. And that's a reduction in the macroeconomic societal cost per patient per year after taking into account the additional cost of the therapy. Because remember, we're comparing apples and oranges, right? We are comparing a situation where we don't have the treatment to a situation where we have the treatment, right? So based on that, it's apples and oranges, right? So to make sure that you have the right comparison, you have to take into account the cost of the treatment. And after taking that into account, the overall cost, the total cost, still go down by about 20%. The third aspect that I'd like to underline is related to the fact that when there is an approved treatment, what happens, and this is very interesting from a financial viewpoint, what happens is that there's a shift in the identity of the payer. If there is no treatment, and this is even more true, the more unknown the disease is, a lot of the costs in that case fall on the caregivers and the family and the patient. When you have a treatment instead, what happens is that the indirect costs go down because in the entire spectrum of essentially the therapy starts revolving around that specific treatment, and everything gets simplified, if you want. The mortality costs go down. This is not always true. It depends on how effective a therapy is, but on average, it is true. And then also the direct costs are reduced, right? They're reduced essentially because, yeah, you're adding the direct cost of the treatment, but in many cases, you're foregoing the costs of other procedures, other treatments. For example, there are some treatments that are organ sparing, and so you might avoid an organ transplant or a hernia procedure and so on. What happens is that the beauty of this is that when you have an approved treatment, that typically the costs shift onto the insurance company, right? Away from the family and the caregiver and the patient. The advantage of this is that, insurance companies are typically much more affluent than specific families and patients, obviously, so they can pay for things. And then secondly, the insurance companies can diversify the risk of paying for a rare disease drug because it's very rare. They can diversify the risk away over a broad portfolio of patients. And therefore, that reduces the risk exposure of the insurance company. And it's something that the patients can't do, right? Because they don't have a portfolio of patients, obviously. And therefore, the beauty of this is that it shifts the burden away from people who cannot pay to organizations that can pay. And that's also true for Medicare and Medicare, who essentially diversify their costs away over multiple people, right? So these are the main findings, and I found them to be pretty interesting. I think the other aspect that I would like to underline for everyone to think about is that we've shown with our study that the cost for the 24 rare diseases that we have analyzed in detail is significant, and it's about $125 billion. So it's a significant macroeconomic burden. However, the even more interesting aspect is that if we extrapolate that number to estimate the cost of the 380 diseases that we've studied, not as deep as the 24, but relatively deeply, the overall cost is estimated at around $2.2 trillion. Okay, and those 380 diseases affect an estimated 8 million to 8.5 million patients, right? So it's a significant macroeconomic burden, and it's something that we will want to discuss further with the authorities and the policymakers in the future to continue to incentivize new investments in incentives for research and development in rare diseases.